Why do we call our meeting Psychiatric Drugs Do More Harm Than Good? That's because the speakers have arrived at that conclusion. We have different backgrounds, but we all agree that this is the case, that we currently use so many drugs in so many ways that they are harmful. Robert Whitaker is going to be the first speaker. Bob, where are you? Robert Whitaker is a science journalist who has published two very interesting books about psychiatry, Mad in America and The Anatomy of an Epidemic, which has been translated into Danish. So we are very pleased that Bob is here to tell us that psychiatry hasn't delivered what it promised. So please, Bob.
It's such a pleasure being here. I think this is my fourth time in Copenhagen and starting to feel like home coming here, so it's great being here. What I'm going to try to do in the next 45 minutes, and by the way, Peter told me one thing about this talk. We don't care what you say, just end on time. Anyway, what I hope to do in the next 45 minutes, as Peter said, is I came at this as a journalist, and in some ways as a journalist, I'm representative of the ordinary person in society trying to think about this issue about how psychiatric drugs affect people over the long term. So one of the things I hope to do today is in the next 45 minutes is also show the approach that I use and I think society can use as they address this question. Is our widespread use of these drugs really helping us as a society or not? Now, the first thing I think it's important to do is to understand the common wisdom. What is the narrative that is out there about medications, psychiatric medications? And this is a quote from a very famous or well-known historian at the University of Toronto. What does he say? He says the arrival of chlorpromazine, I think it was Largactil, it was called Largactil in Europe, represents this great leap forward, the start of a psychopharmacological revolution. And the story is that before this drug arrived in asylum medicine in 1955, we lacked treatments that would prevent people from becoming chronically ill. Then we get this new drug, and you can see he's comparing it to the introduction of antibiotics. Now, there are few things in medicine as important as the introduction of antibiotics. I mean, they took bacterial infections that could kill people and they tamed them in the course of a few weeks. So that's the comparison he's making here, this great leap forward. And as part of this common narrative of progress, this is said to kick off a psychopharmacological revolution, great advance in care. We get antipsychotics. Do you hear that word, antipsychotics, as if they're an antidote to psychosis, a specific antidote to whatever is causing psychosis? Then we get antidepressants. You hear that sense of an antidote? And if you go forward with this story of progress, we eventually hear that these drugs fix chemical imbalances in the brain, right? Like insulin for diabetes. That also is a story of great progress. It means you've identified the pathology of the disorder, and now you have a treatment specific to that pathology. And if that story is true, if indeed they've identified the molecular problem that leads to depression or psychosis, and now you have a drug that can fix it, that is a story of tremendous medical advance. And that's the story we've been told. And if you go forward with this story of progress, we get the second generation drugs, the SSRI antidepressants, the new atypical antipsychotics, which are said to be safer and more effective than the first generation, right? And the first SSRI, which we called Prozac. Do you call it Prozac in here as well? Okay, it arrives on the market in 1988. This is the first of the second generation drugs. In the United States at that time, we spent about $800 million on psychiatric drugs. We now spend $40 billion a year on psychiatric drugs. That's a 50-fold increase. We have 1 in 5 Americans now takes a psychiatric drug on a daily basis, okay? Which tells about how common they are now in our lives. But that's the story of progress that drives this care. And it's also that it made it possible to, take the chronically, seriously mentally ill and treat them in the community, okay? And what we're going to do in the next 45 minutes is put that story of progress under a scientific microscope, okay? Now, the first thing we want to do is if you make medical progress and you get a form of care that is so effective, you should see the burden of that illness actually drop in a society. Does that make sense? I mean, people don't die from bacterial infections generally today with antibiotics. So we should see a decrease in the burden of mental illness in our society. But what you see is exactly the opposite. As this psychopharmacological revolution has unfolded, the number of people under government care, rather than decline, has risen notably. Now, in 1955, we had no social security system for taking care of people in the community. So the people under government care were in hospitals. There were about 350,000 people in U.S. hospitals at that time with a psychiatric diagnosis, and that's a disability rate of about 200 per 100,000 population. Then we, like everybody else, deinstitutionalizes. We say we're going to take our, quote, seriously mentally ill and take care of them in the community. We built up a support system for doing that, payments, that sort of thing. So by 1987, deinstitutionalization is complete. And now you look at the number of people on disability receiving a government check in the United States in 1987, and it was about 1.25 million. So during this first era of psychiatric drugs, the number of people who were in need of government care more than doubled, okay? People may say, well, that's an unfair comparison. You had to be sicker to be on the hospital than you need to be on disability today, so that's an apples to oranges comparison. Now, fortunately, since 1987, and this is the era of second-generation drugs, it's an apples-to-apples comparison. The number of people on government disability due to mental illness. In other words, that's why they were declared eligible. And you can see now it's tripled again on a per capita basis. So during this time when we've been making increased use of drugs, rather than disability numbers go down, they're rising. Now, after I published this data in 2010, people said, that's just in the United States. It's because you guys have a Darwinian system, you don't really take care of people, you don't have national health insurance. It's just the United States. So since then, I've been looking at other countries. This is just the US. How about other countries that do have a better social services program? What you see is this rise in disability is happening in country after country. New Zealand, fourfold increase. Australia, fourfold increase in the last 20 years. Iceland, this is really interesting because Iceland is a very small community. There's only, I think, around 500,000 people. So it was not a market targeted by the drug companies initially. And their use of SSRIs begins to climb around mid-1990s. And look what happens all of a sudden. The number of people going on disability each year begins to skyrocket. And by the way, what's driving the rise in disability numbers is affective disorders. It's depression and bipolar. It's actually not psychotic disorders. How about here in Denmark? Now, this is the number of people going on disability each year, and you'll see it's tripled in the last 10 years, okay? Sweden, same things. The percentage of all new disability cases, it went from about 18% to 60%. So what you see is it's a problem recurring over and over in country after country. Now, this does not prove anything about the merits of the drugs, but it raises a question, right? It just raises a question, what's going on? Why are we seeing these increasing disability rates? Now, the second thing I want to do quickly, he's got me scared at time. I'm already like... The second question we want to do, and then we're going to get into a review of the evidence base for antipsychotics. You're going to hear about antidepressants later. I'm going to talk about stimulants. But the second thing we want to ask ourselves, is it true that they fix chemical imbalances in the brain? Is that part of that common narrative true? Okay? Now, what you find if you look at this is that whole theory, that hypothesis, arose not from an understanding of what was happening in people diagnosed with depression or schizophrenia, but how the drugs acted on the brain. So, for example, going back to the 60s, they came to understand that antipsychotics blocked the passage of messages from one neuron to another. So how do neurons in the brain communicate? How do they pass messages? You have a presynaptic neuron that will release a molecule, which we call a neurotransmitter or a chemical messenger, into that tiny gap between neurons, right? And then that molecule, say dopamine or serotonin, binds with receptors on the second neuron, which is the postsynaptic neuron. We say that molecule fits into that second receptor like a key into a lock. Have you heard that metaphor? Okay. Now, that's how this will either excite or inhibit the activity of the second neuron, and then you have to have a means for removing that neurotransmitter from the synaptic cleft in order to end the message. And that molecule is removed from that space in one of two ways. It either goes back up into the presynaptic neuron, or an enzyme comes along, metabolizes the serotonin or the dopamine, and those metabolites are carted off as waste. So what did they discover in the 60s, early 70s? They discovered that antipsychotics, the way they work is they block the receptors on those receiving neurons. Think of those as the lock, and what they do is they gum up those locks. So now the molecule, the dopamine, can't fit into those receptors on the receiving neuron, okay? And they block a particular type of receptor called a D2 receptor. That's not so important. And at a therapeutic dose, they block about 70% of all those D2 receptors. So they're inhibiting the transmission of dopamine from one neuron to the other. Now, based on that understanding of how the drug works, researchers said, aha, maybe schizophrenia is due to too much dopamine, okay? So the hypothesis is born from the mechanism of knowing about the mechanism of the action of the drugs, not what is happening in people, okay? So how about SSRI antidepressants? What do they do? SSRI antidepressants block the reuptake, the removal of serotonin from that synaptic cleft into the presynaptic neuron that discharged it. Because it blocks that reuptake process, serotonin now stays longer in that gap between neurons. We say it ups serotonergic activity. And so because we understood that it ups serotonergic activity, we said, well, maybe the problem with depression is it's caused by too little serotonin, okay? That was the origins. But now after they have this hypothesis, they have to see, do depressed patients, before they go on an antidepressant, do they have low serotonergic activity? Or do schizophrenia patients, and I'm just using the diagnostic term, okay? People so diagnosed, do they have too much dopamine in activity, okay? And therefore, the drug helps bring it back into balance, okay? Now, what you find, this is a long search for this, but what you find is they didn't find that to be so, okay? They did not find that, as a matter of course, people with depression had low serotonin. They did not find that, as a matter of course, people with schizophrenia or psychotic disorders had overactive dopamine systems. And I'm going to just show you this. As early as 1984, the NIMH, that's the National Institute of Mental Health, which is our big agency for funding research into mental disorders, okay? So this is the top mental agency. This is our government funding this research. And what did they conclude in 1984? It doesn't look like there's a problem with the serotonergic system. We're just not finding it. And by the way they measured this, the way they looked at this, remember I told you that that molecule is removed from the gap in two ways, either back into the presynaptic neuron or an enzyme comes along and metabolizes it? Well, they said they could measure those metabolites in the cerebrospinal fluid, and they said, well, if depression is due to low serotonin, we should see then low levels of those metabolites, and they didn't find it, okay? So who's Stephen Stahl? He's a molecular psychiatrist. He believes that we're going to find the molecular keys to these things. But he writes a textbook. He's very well known. And what did he conclude in 2000? There is no clear and convincing evidence that monoamine, serotonin is a monoamine, okay? Deficiency accounts for depression. That is, there is no real deficit. How about schizophrenia? Who's Stephen Hyman? Stephen Hyman is a former director of the NIMH. My point is, I'm presenting to you the conclusions of people who did the research, okay? Very mainstream, prestigious people. What does he say? There is no compelling evidence that a lesion in the dopamine system is a primary cause of schizophrenia. Didn't find it. Who's Kenneth Kendler? One of the world leaders in searching for chemical imbalances. So what does he write in 2005? We have hunted for big, simple neurochemical explanations for psychiatric disorders, and we have not found them. Now finally, this is my favorite quote. Who's Ronald Pies? He's the former editor-in-chief of Psychiatric Times, which is basically a publication of the American Psychiatric Association. Now this story of chemical imbalances has fallen so completely apart in the United States. I'm sort of, the one place it still lives is in Sweden, oddly enough, quite a bit. And Denmark. Well, it's partly in Sweden because their scientists were integral to creating it in the first place. But what does he say? He says, in truth, the chemical imbalance notion was always a kind of urban legend, never a theory seriously propounded by well-informed psychiatrists. So what psychiatrists at the top of this are saying now in the United States, we never said this. And I was giving a grand rounds at Massachusetts General Hospital, which is a Harvard hospital many years ago, like 5 years ago. And they were mad, and it was sort of a debate situation. And they were mad at me. They said, you know, you made us look bad by saying we told people that there were chemical imbalances. And the guy says, we knew that was outdated 25 years ago, 1985. And I said, you know, you're right. You did know it was outdated and it had fallen apart in 1985, but I'm pretty sure you forgot to communicate it to the American people. And it's absolutely true. You can still go on websites today, run by the American Psychiatric Association or patient advocacy websites where they have scientific advisory boards by the most important people, and they say these drugs fix chemical imbalances. My point to this is that part of the narrative is false. And you can see that we have been laboring under a false story, okay? Now the next question is, if they don't fix chemical imbalances, what do they do to the brain? Okay? And how does the brain respond to the drug? And this is really key. So, again, this is a paper written by Stephen Hyman in 1996. He's putting forth a paradigm for understanding how the drugs act on the brain. So you take an antipsychotic. It blocks all those D2 receptors, okay? That's an abnormal thing to do, right? Now your brain having this incredibly neuroplastic, you all know that word, organ, it changes, it adapts to its environment. So if you have a drug that blocks dopamine action, what do you think your brain does? It's going to try to increase its own capacity to pass messages along its dopaminergic pathway. And it will do that in two ways. One, the presynaptic neurons will put out more dopamine than normal for a bit of time. That compensatory adaptation tends to break down. And then the receiving neurons, the postsynaptic neurons, will actually increase their number of, the density of their neurons, receptors for dopamine, okay? And so think about this. The drug acts as a brake. The brain is putting down the accelerator on that. And if you read this carefully, he's saying that's what this does. The drugs, you know, they perturb normal function. Then the brain tries to adapt to it, okay, in the way I said. Watch this. Chronic administration of the drugs then cause substantial and long-lasting alterations in neurofunctioning. They're inducing abnormal functioning, okay? And look at the last thing. After a few weeks, the person's brain is now functioning in a manner that is qualitatively as well as quantitatively different from the normal state. So again, if we put this common narrative under a microscope, our society thinks they fix problems, like insulin for diabetes, but if you really look into the science, they're perturbing normal function. Your brain adapts to that, and now your brain ends up in an abnormal state. And the irony is, in fact, the drugs induce the very problems hypothesized to cause these disorders in the first place. Remember I told you that they hypothesized that schizophrenia was due to too much dopamine activity? Well, one of the things they looked at is, well, maybe the hyperactivity is due to too many dopamine receptors, okay? And at autopsy, guess what? They found that to be so. They looked at the brains of people with schizophrenia, and they had maybe 50% or 100% or double the number of normal receptors. Initially, the researchers said, we found the cause of schizophrenia in the brains of these people. They have too many dopamine receptors. Hallelujah. But then you got to read the paper. They said, we don't know if this is due to the disease or the drug. And they eventually came to understand it was due to the drugs. There's still some effort to see if there's some patients, if there's some sort of abnormality with dopamine subgroups, etc. That hasn't completely died. okay? The simple dopamine overactivity hypothesis really died, at least in the United States, in about 1992. But there are still some groups that say they're still searching for abnormalities in dopamine function, okay? Anyway, this is just a simple, think of dopamine function before exposure to antipsychotics, and this is what I'm talking about, increasing the number of receptors, okay? Now, what researchers have said is this, is that these drugs induce an oppositional tolerance, okay, in the same way that addictive drugs do. They induce the opposite effect of what is originally intended, okay? And now, who's Reef El-Malik? Reef El-Malik is an expert in mood disorders, okay? He used to do work for Eli Lilly, so this is not someone outside. But he and others now looking at why do these disorders run such chronic courses today are looking to this explanation. And you can see, continued drug treatment may induce processes that are the opposite of what the medication originally produced. That's just what I explained to you. The antipsychotics increase the number of dopamine receptors. They cause a dopamine supersensitivity. So what happens if you go on an SSRI? SSRI causes more serotonin to stay in the gap. It acts as an accelerator. Your brain, to retain its normal function, to try to retain what they call a homeostatic equilibrium, will now dial down its serotonergic machinery. The presynaptic neurons will put out a little less serotonin than normal. Not sure how long that compensatory adaptation survives. And then the receiving neurons will dial down their number of serotonergic receptors, okay? And that's the general understanding of oppositional tolerance, okay? The brain, as Stephen Hyman's saying, is trying to retain a normal functioning. Now, he's an expert in mood disorders, and he says, what does he say? This may cause a worsening of the illness, continue for a period of time after discontinuation of the medication, and may not be reversible. What I'm trying to tell you here is a story of science in which researchers had a hypothesis, valid hypothesis, did not find at least a simple chemical imbalance story that these drugs were fixing a known imbalance was true, found instead that the drugs induced these changes, and now as they've started looking at the chronic course of mental disorders, some people are saying maybe this is the problem. The drugs induce the opposite effect of what was originally intended, okay? Now, what I'm going to do now is a really quick case study of trying to figure out how do antipsychotics affect the long-term course of schizophrenia and other psychotic disorders. Now, in this narrative of progress, antipsychotics sit at the heart of this narrative of progress, okay? Because it is said that antipsychotics are the very drugs that made it possible for people to live outside the institution. And at least when I first wrote Anatomy of an Epidemic, in that book, as you'll see, says that, wait a minute, if you look at long-term, these drugs are increasing the chronicity of psychotic disorders. But we'll get to that. That was an idea that was considered heresy, okay? That's ridiculous. We all know these drugs improve the long-term course of schizophrenia and psychosis. And just to give you an example, the very first review of Anatomy of an Epidemic likened me to an AIDS denier. Now, if you're likened to an AIDS denier, you call it AIDS here in Denmark as well, it means this is the most unscientific guy you've ever seen. Don't read this book, okay? But that was 6 years ago. And what I'm going to present here today in the next 28 minutes is a very quick summary when you try to answer this question. What is science telling us about the long-term effects of antipsychotics? Okay? And by the way, we're going to focus on the benefit side of the equation. Do they really decrease psychosis, et cetera, over the long term? We're not even really going to get into all their side effects, okay? So how are we going to, I'm a journalist. How am I going to try to address this question and even think about this question about how these drugs affect long-term outcomes? Well, the first thing I need to do is I need to know what is the evidence base for their use, okay? What is the evidence that says these drugs are effective? And in essence, I think there's three types. One, you do short-term studies. People come into a hospital. They're randomized either to drug or to placebo. And I know Peter's going to laugh at this in a second, but in the short-term studies, the drug-treated patients had a greater reduction of psychotic symptoms. That's the efficacy. Now, the reason I said about Peter is Peter knows there's been very few studies in drug-naive patients. Okay, so even this short-term basis is compromise. But let's just grant that, okay? The drugs work over the short term. They knock down the symptoms better than placebo. Now, the second is you're a doctor in the 1960s. You're using these drugs, right? You give them to your patients in the hospital. What's your next question? How long should I keep people on the drugs, right? So they ran studies designed like this. They took that subgroup of patients that had stabilized well on the drugs, not everybody does. Half were abruptly withdrawn from the drug. Half were maintained on the drug. And with great regularity, this half that was withdrawn from the drug, they relapsed at a higher rate, okay? In other words, their psychotic symptoms came back. So what did the doctors say? Aha, there's lower relapse rates over here in this group. The drugs prevent the return of the disease, or they lower the risk of the disease, okay, returning. And therefore, I need to keep people on these drugs indefinitely, okay? And that was the rationale. And that's still the evidence base for long-term use, withdrawal studies. Now, most of them are abrupt withdrawal. There's very few gradual withdrawal, but that's the evidence base for long-term use of these drugs, and you can go find that. I think there in some ways is a much more compelling third sort of part of the evidence base. Now, I'm a doctor. People come into my hospital. I give them the drug. I see that they get better, right? Okay? Then they go home, they say, I hate these drugs. They throw away the drugs, they relapse, they come back to me. So what's my clinical experience? They need to be on the drugs, okay? So that is the evidence base for the use of these drugs. Now, next question, is there anything missing from that evidence base? And you can see right away that there's some problems with it. Do those relapse stories, do they tell you, so you're the drug maintain group, okay? Do they tell us how they're functioning long term? Do they tell us whether they're working? Do they tell us they have a social life? And do they really tell us, like over the course of 2, 5, 10 years, are they coming back to the hospital? They don't. What the evidence base tells us is, once on the drug and stabilized, if you withdraw that, there's a lot of risk of relapse. But it doesn't really tell us what is happening to the lives of this group of people on the medications. Second, there's a clear flaw with the drug withdrawal studies. You go on an antipsychotic, it blocks dopamine, right? Your brain accelerates the dopamine activity. You have the accelerator. Now you do with the withdrawal study. You take away the drug, what do you got? You still have a changed brain, right? So maybe what we're really seeing in these studies is partially a drug withdrawal risk as opposed to the return of the normal course of the illness. By the way, there are actually very few studies out there where they tried to get people off medication successfully and slowly. And third, how about the clinical experience? Does the doctor today have any experience watching the long-term unmedicated course of, quote, schizophrenia? They don't see it, right? So they don't know the natural course. That's the limit of the evidence base. Now follow me here. This is important. Because if you write something like this, you'll be accused of bias, that sort of thing, all right? Or that you're cherry picking. So my next step in the scientific literature was to see, well, are there other types of studies that show that the drugs are improving the long-term course? Now, we're talking 50 years of literature, so what did I do? First thing, I went to those who have done such searches, who believe in this narrative, and could they point me to studies that say these are the studies that show we're improving the long-term course? And if you do that search, here's what you find. Who's Emmanuel Stipp? He's a pretty well-known psychiatrist from the University of Montreal. And in 2002, which was the 50th anniversary of the discovery of Largactil, chlorpromazine, he says this: after 50 years of these drugs, are we able to answer the following simple question? Are these drugs effective in treating schizophrenia? What does he say? There is no compelling evidence on the matter when long-term is considered. And then read the second part of this. If we wish to base psychiatry on evidence-based medicine, we run a genuine risk in taking a close look at what has long been considered fact. Meaning, we may be surprised by what we find. Now, for me as a journalist, this was really key. This is a green light, isn't it? This is saying it's a valid, it's not a biased thing to try to figure out what the research has to say. It's a valid scientific enterprise. Okay, in the interest of time, I'm going to sort of really go through the first 20 years real quickly. If you go through the first 20 years, here's what you find. If you look at the clinical experience of doctors at this time, who, when the drugs are introduced, and they've been used to seeing the course of unmedicated schizophrenia, right? They'll say, boy, we're noticing something. Our patients are getting better faster. We can discharge them from the hospital faster. By the way, before the introduction of chlorpromazine, first episode patients were being discharged regularly, okay? But anyway, we're getting patients out faster, but boy, are they coming back to the hospital in droves. And they invented a term called the revolving door syndrome to reflect that the people were coming back all the time, okay? That's a clinical impression. Another clinical impression was, the other thing that seems odd, and this came from the very top of the NIMH, when people relapse on drug, it seems like the relapse is more severe than we used to see, okay? So because of some of these concerns, there were a series of studies funded in the 1970s meant to revisit how are these drugs affecting the long-term course of patients so diagnosed. Now, one, in the very first study was done by the NIMH. It has 4 arms. 3 groups get drug, 1 group gets placebo. At the end of 6 weeks, the drug-treated patients are doing better, okay? But many of the placebo patients have improved. They're discharged in the community, and at the end of 1 year, they notice something odd. Those treated with drug in the hospital have been rehospitalized at higher rates than the placebo group. So at this very first moment of the research literature, we see the vaguest hint of a paradox of drugs that may be effective over the short term. Could they be increasing the relapse rate over the long term? Then we had someone named Sanford Bachhoven. He had 5-year data for people treated in 1947 without drugs. He has a similar group of patients. He matches them treated in 67 with drugs. And he notices that at the end of 5 years, the 1947 cohort had a lower risk of relapse or rehospitalization and a much higher social functioning than the modern group. And he says, if we're interested in long-term outcomes, we may need to rethink what we're doing with these drugs, okay? Then there were 3 studies in the 1970s funded by the NIMH that basically were meant to do this. Let's look at the end of 1, 2, and 3 years, okay? We'll have 1 group treated conventionally with drugs, and this unconventional group would either not get treated with drugs at all, exposed with drugs, or it would be done very selectively in a limited manner, okay? And what happened was, at the end of longer periods of time, this group, treated conventionally with drugs continually, had higher relapse rates, in other words, they came back to the hospital more, and lower functioning, every time, okay? So watch what happens in 1977. Now one of those 3 studies was conducted at the NIMH by William Carpenter, who's still a famous name in schizophrenia. And he's trying to make sense of the literature. He says, we have these relapse studies where you take the drug away. Boy, people relapse at higher rates. That's one bit of evidence. But now we have this other evidence where we don't initially put people on drugs, and it seems like that leads to a lower relapse rate. Okay? So you can see a mind working here. There's no question that once patients are placed on medication, they're less vulnerable to relapse if maintained on the drugs. That's the relapse literature. But what if these patients had never been treated with drugs to begin with? We raise the possibility that the medication may make some patients more vulnerable to future relapse than would be the case in the normal course of the illness. 1977, this worry about oppositional tolerance is rising, and here's the worry. Maybe the drugs are inducing a biological change that makes people more biologically vulnerable to psychosis. This is the worry that arises. And this is key to all the research literature on psychiatric drugs. It's the antipsychotics that are the best studied for long term. And now we get a hypothesis from 2 people at the University of, at McGill University in Montreal, Canada. He says, we think we know what's happening. We can explain this paradox. These drugs are inducing this upregulation, this increase in D2 receptors, dopamine receptors. The brain is now super sensitive to dopamine. It's more sensitive than it should be. And when this happens, the tendency toward psychotic relapsers develop such a supersensitivity is determined by more than just the course of the illness. So they're really worried about 2 things. You go on the drug, it blocks dopamine. Your brain puts down its accelerator on dopamine. Now you take it away, that's going to make you, the fact you're now super sensitive to dopamine is going to make you very vulnerable to relapse. But they're also going to worry that once you get this physiological change, you're going to be more likely to become chronically psychotic, okay? And they called this tardive psychosis, and they studied this, and they said after 10 years, about 30% of our patients are showing signs of becoming chronically psychotic on these drugs. When this happens, they wrote, the illness appears worse than ever before. New schizophrenic symptoms of greater severity will appear. Do you feel your breath going away? Imagine when Barry Jones and Guy Chenard presented this to psychiatrists in the early 80s. What do you think the reaction was? Disbelief. There are stories of psychiatrists standing up saying, are you telling me the very drug I used to curb psychosis, to treat psychosis, is making these people more psychotic over the long term? Can't be. There's a cognitive dissonance there. They can't accept it because in some ways, this is science illuminating a paradox that the clinician doesn't see. So what are they going to believe, their own eyes or this literature? What I'm telling you, it's difficult. Okay, but this worry, you can see the worry arises. Now the question is, we see the worry arise in the next 15 minutes. What does the evidence sense then tell us? Is this a real worry, or can we put this worry to rest? Okay? And I hope what you see here is we're trying to see what a history of science tells us, okay? And what I'm going to do in the next 15 minutes, I'm going to try to find whatever studies I can find of any type that bear on this question of how antipsychotics affect long-term outcomes. First of all, the World Health Organization, beginning in the 70s, conducted two longer-term cross-cultural studies. And what they did is they compared outcomes in India, Nigeria, and Colombia, which were labeled the developing countries, with outcomes in the US and other rich countries. One of the, I think, I'm going to mispronounce this, Aarhus was one of the centers in the study, if I remember correctly. So there was a Denmark part. Now, in both studies, 2 years in length and 5 years, you see the best outcomes in the developing countries, okay? Specifically India and Nigeria, okay? Look at the second thing. The WHO researchers concluded that being in a developed country was a strong predictor of not attaining a complete remission. By the way, it was this finding that made me curious about this whole subject 15 years ago, or more than that, 17 years ago. Why should living in a developed country be a predictor you won't have a good outcome? Okay? You'll see exceptionally good outcome. So after the first such study, 5 years in length, and by the way, people were diagnosed by Western standards, okay? They hypothesized maybe the reason for the better outcomes in the poor countries is the patients are more compliant. They take their medications. Valid hypothesis. If the drug is essential, compliance should be associated with better outcomes. So they measured medication use in the follow-up study, and what did they find? That in India and Nigeria in particular, they just weren't keeping patients on the drugs long-term. They would use them acutely, but not long-term, and that's where they had the best outcomes. Okay? Now, and you'll see that showed up that the outcome differential maintained as they went back 15, 20 years. I will tell you a recent study, and then I got to start hurrying, done by Eli Lilly, 3-year study. It's, I think, 11,000 patients in 37 countries, something like that. The outcomes are no better anymore in the poor countries. In fact, they're a little bit worse. But in this new study, everybody was maintained on drugs continually for 3 years. And it's not that in this new one that the outcomes in the rich countries have elevated. It's that now the outcomes in the poor countries functionally are no longer so good. Okay? Anyway, that's one data point. In interest of time, I'm not going to go through this, but real quickly, I guess I am going to go through it. Philip Seaman, who was one of the guys who discovered how the mode of action of these drugs, he developed an animal model for psychosis. He developed various ways to induce what he called like psychotic behavior in rats and all. He would give them drugs like angel dust. He would do lesions in the drug brain. And he noticed that they all had the same common pathway in the end. And what was the final common pathway? They all caused an increase in D2 receptors. The very thing that drugs do, antipsychotics do. So he found that all these insults to the brain cause the very same change you see caused by the drugs, okay? And he says this, and he says, this is why drug treatment fails over time. So he did a study in which he made his rats psychotic with an hallucinogen or with a lesion to the brain. He gave them an antipsychotic. The rats renormalized initially, blocks those D2 receptors. But then the drugs now, he takes away the insult, and the only thing that is remaining is the drug. Those drugs continue to increase D2 receptors, and he says the rats return and becoming psychotic again. So animal research says this is why the drugs fail over time. Data point 2. Now MRI studies. We can now study brain volumes. Who's Nancy Andreasen? Nancy Andreasen is the longtime editor-in-chief, or was, of American Journal of Psychiatry. A very mainstream person, obviously. She wrote a book called The Broken Brain. Now, she hypothesizes in the mid-90s, schizophrenia is a progressive degenerative disease characterized by a decrease in brain volumes, okay? All right? And what does she find? She finds that, yeah, I measure the volume of the brain when people come in, and 5 years later, their brains are smaller, okay? But she says that's the disease, all right? That's the finding. Then next she reports, as you get this loss in brain volumes, you get worsening and negative symptoms. That's the apathy, increased functional impairment, and after 5 years, cognitive decline. And so what she's saying is you have this disease process characterized by loss in brain volumes that is not arrested by the drugs. Unfortunately, the drugs don't stop that. But you give these drugs to monkeys, which presumably do not have schizophrenia, and their brain volumes decline as well. So that means like maybe it's the drug and not the disease, or some combination of both, right? So what does Andreasen? She goes back and looks at her own data, and in 2011 she reports this shrinkage is drug-related. Use of the old drugs, the new drugs, and clozapine were all associated with smaller brain tissue volumes, decreases in both white and gray matter. Severity of illness and substance abuse had minimal or no effect on brain volumes. I will tell you where I believe that this research now, there's really good data that these drugs do indeed shrink the brain over time. The question is there a disease, is there something happening that also causes this? In other words, maybe you're going to see some smaller brain volumes even at initial diagnosis. I think that's possible, but there are many things that can cause this, trauma, that sort of thing as well. But there's still sort of an open debate, in my opinion, because there was one group of researchers that really controlled for this, and they said, do you see loss in brain volume in unmedicated people long-term? And they didn't find it, okay? So it's sort of an open question. But the point is this, you have research that is saying we have a drug that causes a morphological change in the brain, and that is associated with poorer long-term outcomes. Another data point. I'm going to skip this, but you'll see German researchers just looked at this and said, boy, this evidence is really compelling. We need to rethink the use of these drugs. Okay, long-term outcome study. This is a prospective study beginning in the late 70s, early 80s. A person at the University of Illinois, he enrolls 200 psychotic patients into a study, and he's just going to follow them long-term. It's a naturalistic study. Everybody treated with drugs in the hospital, this discharged, and he's going to look them at 2 years, 5 years, 10, 15, and 20. It's a young cohort, many first episodes, so we're getting people a long-term course. His hypothesis is this: the people who on their own choose not to take medication are going to do horribly long-term. That's the expectation. What does he find? Now, this is on the target symptom. This is in 64 of the 200. After 15 years, he still had 145 in his study. That's a really good retention rate. Of the 145, about 64 have a diagnosis of schizophrenia, the others milder disorders. Now, about 20 had quit their antipsychotics by year 2. They're still psychotic, folks. You see that? Those off the drugs are still psychotic. There's no difference, right? 60, 70%. But look what happens between year 2 and 4.5. This is the only place in the research literature you're going to see this capacity for healing. You see what happens off meds? The number's still psychotic. By 4.5 years is only 20%. So that's a natural healing process. These people are not in care. They've dropped out. Okay, and you see it's like that. By the end, it's like less than 10% are psychotic. Now, how about those who stay on the drugs? The drugs that are not working on the target symptom, you'll see like 70% remain psychotic. Okay, how about anxiety symptoms? Same thing. At the end of 2 years, people off the drugs, they're not doing well. Folks, they're very anxious. But look what happens healing between year 2, 4.5. It's the only place you see it. Cognitive function, better off. Long-term recovery rate. To be in recovery, you had to have a pretty good social functioning, and you need to be asymptomatic. Again, it's between 2 and 4.5 that the outcomes diverge, all right? You see that? So recovery rate by the end is 40 versus 5%, 8 times higher off drugs. Here's the spectrum of outcomes. It's not just that there's fewer in recovery. So what's the spectrum? Off meds, 40% recovered, 44% okay, only 16% really bad. How about on drugs? 5% recovered, 46, 49% uniformly poor. It's as if you've shifted your outcome to drug use, a more chronic course. What does he conclude? So what the researcher of the best long-term study we've ever had concludes. How many of you have heard of this? Okay? We don't hear this. Now, just real quickly, this is the milder patients, people with schizoaffective disorder, manic episodes with psychotic feature, depression with psychotic feature. Again, you see better outcomes for those who get off. Now, look at this slide. This is the key slide. He's got 4 groups: schizophrenia on and off, milder disorders on and off. Worst, schizophrenia on meds. Second, milder disorders on meds are worse than schizophrenia off. Do you see the problem here? Why would milder disorders at prognosis, means they have a better long-term prognosis, do worse than schizophrenia off long-term if the meds weren't iatrogenic, causing this long-term chronicity? Okay? Now, what does our lead researcher say? How unique among medical treatments is it that the apparent efficacy of antipsychotics could diminish over time or become ineffective or harmful? Many examples of this happening. That's from the best long-term study. Another data point. This is a randomized study. The complaint about Harrow is that it was naturalistic. There's some self-selection going on. We now have a randomized study from the Netherlands. Everybody stabilized on the drugs, okay, and then half they try to gradually taper down, either to a low dose or off. This is drug care as usual. This is really interesting. You see the number of relapses at 2 years? It's higher in the drug reduction group, which does show that there's this risk when you try to get people off. But you know what? They managed a lot of these. They didn't need to be re-hospitalized as they got them through that. At the end of 7 years in this study, there's no difference in relapse rates, but how about functional recovery? More than twice as high in the drug reduction group. Okay, better functional outcomes. Now, in that 7 years, after 2 years, people were free to do whatever they wanted, and so you can actually, some of the people in the drug maintained group took themselves off. Now, this is a grouping by drug use at the end. You'll see greater symptom remission in those off, much greater functional remission, much greater full recovery. So now we have a randomized trial. I would just say, what has Wondering said? These drugs may impair long-term outcomes. And folks, we've been looking at the wrong thing. Those relapse studies focus on a narrow period of time. We need to look what happens long-term, because that may be very different. And we've been missing it. Our research has been missing it. Okay? There was an Australian study. This study, I got 2.5 minutes. The Australian study was done like this. Everybody stabilizes. And the idea was, again, people don't like these drugs. So we're going to have a special social care program to ensure that, to try to increase medication compliance. You're the medication compliant group. You're the group treatment as usual. We tell you to take your drugs, but you people, you don't take your drugs. So what happened? It worked. The social care increased compliance. Okay? You were more medication compliant. The problem is increased compliance was associated with decreases in functioning and increases in negative symptoms. So this group was doing better. Okay? What does he say? This is consistent with previous research showing an association between better vocational functioning at 2-year follow-up and placebo. Once again, if we're looking at functioning, what are we seeing? This is, again, I told you at the beginning of this, in 2010, I was treated as a heretic, right? For suggesting that antipsychotics did not improve long-term outcomes. Really, you need a form of care that makes selective use. We could talk about that. British Journal of Psychiatry is now saying, there is an increasing body of evidence that the adverse effects of treatment are, to put it simply, not worth the candle. British phrase for they're doing more harm than good. Even our director of the NIMH, who apparently has just resigned, he's saying the same thing finally. Do these drugs impair long-term recovery? So, finally on this, what have I tried to do here in the last 44 minutes? I've tried to say there is an approach to thinking about this, right? Okay, first we figure out why the drugs are seen as effective. What's the evidence base? Then we see the flaws, and then we go through this history of studies that try to say, how do these drugs affect people over the long term? In the aggregate, people have different responses to these drugs, okay? I'm just saying in the aggregate. And what you see from that history is this worry arises by 1980 that the drugs induce these changes that actually make people more vulnerable to psychosis. And by the way, I'm not talking about adverse effects. I'm talking about the effects on presumably the benefit side of this equation, okay? Because all drugs have risks and benefits, right? Risks, benefits. I've been focusing on this side of the equation, not even talking about all the adverse effects. And so what do we see since 1980? Is that worry a real one or not? What do we have? Cross-cultural studies, negative for antipsychotics. Animal modeling studies, negative for antipsychotics. MRI findings, negative for antipsychotics. Prospective longitudinal study, that's Harold's, negative for antipsychotics. Randomized study, negative for antipsychotics. Drug compliance study, negative for antipsychotics. Now, what I'm saying to all of you, you're the society, right? You have to decide whether this is convincing. It is to me, it may not be to you. But in my opinion, if the drugs are really effective, and in an evidence-based model, who's the responsibility for? It's on the providers, in fact, to have evidence that we're improving the long-term course. And last thing on this question, it doesn't mean that nobody's doing well on the drugs. But let's go to Hippocrates. Hippocrates says, do no harm, right? What does that mean? We think it means don't make your patient worse. It's actually much more complex than that. What Hippocrates was saying is, there is often in nature a natural capacity to recover. And your intervention has to beat that natural capacity to recover in order not to do harm. Okay, so let's imagine that you have a disease. You give a treatment, 50% are cured, no one gets worse. Have you met your Hippocratic oath? Hippocrates would say, no, we don't know, because we need to know the natural course of the disorder. Because maybe the natural course is that 70% recover, and that's really what we're talking about here. Thank you. I'm right on time.
I am full of enormous sympathy for what you have done and what you have said, but I do not think that denying facts will help the cause that you speak so eloquently for. Do you deny that patients with psychosis are sick, is my first question. Secondly, do you deny that there is evidence of increased dopamine in the acute state of drug-naive schizophrenics? And the third question, on that basis, do you advise against the use of drugs that reduce or block the effects of dopamine in the acute phase? Thank you.
Okay. I honestly think in terms of the pathways to that first acute episode of psychosis, there may be many pathways, okay? There may be many different causes to get to that moment. Something's not going right? I honestly don't think we know exactly what's not going right, and I honestly believe in some cases there's something biologically just wrong, okay? In other words, organization of thoughts, certain insults. I believe in this quote, you hear some people talk about group of schizophrenias. I don't particularly like the term, but in other words, there can be a lot of divergent things happening, okay? Second, I think the evidence in terms of the acute use of the drugs, certainly many people respond quite dramatically to antipsychotics. You hear this all the time. I'm just trying with the evidence-based literature, the only thing we're lacking here on acute use is in drug-naive patients. There just haven't been many studies over 6 weeks' time. And the third, in terms of, are they fixing that acute release of dopamine? In my opinion, when you try to study this, the factor of dopamine release in psychosis, it gets confusing, to be honest with you. The history goes like this, up and down. And as sort of a cause of a basic cause of schizophrenia, you see, for example, John Kane in 1992 is the simple dopamine hyperactivity thesis is no longer credible, okay? And it was born by Arvid Carlsson in Sweden, as you know. He was a very important person here.
And there are at least 20 studies showing increased capacity for dopamine synthesis in drug-naive schizophrenics. I could cite all of these 20 studies.
Can I finish? Yeah.
Yes.
But from my understanding is it may be at this moment of crisis, this moment of eruption of psychosis, acute or a temporary increase in dopamine, which actually would fit with the animal model of semen. And if that is so, well, then maybe you do have a rationale for acute use, okay? So, yes, but I'm not denying anyway.
You did in your talk.
What I'm saying
You
is...
said it was wrong. You said that there was no evidence of increased dopamine.
No, I said that that there's not an evidence that there's a lesion. I can go psychotic. And maybe the mechanism for going psychotic is I have extra dopamine release. That's a difference than saying that you have a deficiency or an eternal problem like high dopamine as a long-term problem like insulin for, and then the drug becomes like insulin for diabetes. That's what I'm talking about. That chemical imbalance story that says there's a characteristic underlying pathology that endures that is fixed by the drug. When you talk about acute use, it's a different question, okay?
But then say that, please.
Okay, well, I said it now.
Thank you.
Okay. Thank you so much for this relevant and interesting discussion. I mean, what starts a psychosis? Does dopamine come later as a response to something else? And there is a lot to be said about this.
I read a couple of years in the newspaper a research showing that so-called alpha males and females had a high level of dopamine activity. And it's quite funny because in the evolutionary psychiatry, there's a theory that people labeled with diagnosis in the schizophrenic spectrum should be understood as potential leaders. So I thought, well, there might be a connection. If leading males and females amongst humans have a permanent high dopamine activity level, and if people with these labels should be understood as potential leaders, we might come a step forward.
The neurotransmitter activity changes all the time. It's not a steady state function. So, I mean, I think in some ways this whole thing begins with a misunderstanding of the modulation of neurotransmitters as a way we respond to the world. So.
I just want to talk about that the dopamine theory, of course, the brain is designed to react to the environment. And I don't know how much you've been following the traumagenic model, which indicates, which shows that actually children who are severely traumatized in childhood have a similar brain if you're going to use the scans, which of course, how much does it say, to people with so-called diagnosed schizophrenia. And I know that Andrew Moscovich, who's been actually very involved in that, is coming later and could probably say considerably more. But what it is that trauma is something that is so prevalent and of course affects the brain, including the dopamine. And I think, again, we're back to the hen or the egg kind of thing.
There's all sorts of research correlating traumatic experiences, even in early childhood, with later risks of mental disorders, of being diagnosed. And of course, we human beings, that's what we are. We have this incredible brain that is meant to adapt to the environment, and the brain is changed by the environment. There's no question about it. And I think that's what we're learning, is how much we're changed by the environment and how much stress, violence, trauma it does. It changes you. It's absolutely true. If you can create situations that are more supportive, nurturing, get people involved with each other, less isolating, that form of care, it changes your brain as well. So I mean, it's not just that the brain doesn't change, the brain changes in response to psychology as well, psychological interventions.
How do you respond to the consideration that's put forward by psychiatry that in present time we are way better at actually finding the diseases? We are way better in diagnosing, and that's why the statistics go up. That's why we have more kids with ADHD and stuff like that. How do you respond to that?
Well, again, if you actually have diseases that once upon a time were untreated, and now you're better at recognizing those diseases and getting them effective treatment, then the burden of those disorders should go down, not up. Listen, they don't diagnose ADHD, they don't give you a blood test, they don't do anything, they just say, are you fidgeting too much in class? I mean, is that a disease? You fidget too much in class? I mean, really, ADHD, you brought it up, and I'll talk about it later, means you don't adjust as well to school as your teacher would like, and maybe your parents would like.
I would like to ask you whether you know something about what the patients who don't get treatment with drugs, whether they seek another type of treatment, maybe therapy or maybe psychoanalysis or maybe social care or what, because that will be interesting to know whether another things have helped them out of their psychosis.
If you look at the Martin Harrow study, that group that stopped taking drugs, they disappeared. They stopped going to their psychiatrist. They, in fact, melded back into society by and large. Many of them still seen as odd, but those people became a lawyer, professor, etc. They did it on their own, is the point, without sort of support from others. So really what you see in the Harrow study is the capacity of people to recover even in the absence of treatment. Now I think good treatment, supportive treatment, hearing voices stuff, open dialogue stuff, can improve on that natural resilience. But that was the brilliance of the Martin Harrow study. They found people who disappeared from the system. What they said is this: the people who quit their drugs and relapsed, they came back. That's who the doctor saw, the ones who couldn't get off their drugs successfully. The ones who got off their drugs against doctors' wishes, they didn't come back to their doctor and go, hey, I'm doing good. And they also, once they were in society, they stopped identifying as having been diagnosed with schizophrenia because it's so stigmatizing. So we don't see those, he says. We don't see those successes. But here's the amazing thing. They did it without help of maybe family and that sort of thing. But without, so it's a natural capacity to recover we're seeing. We should be able to improve on that.
People who were around 9/11 at the time of that happening and had a traumatic experience had a decrease in gray and white matter in the brain. Have you found any studies that shows this?
You know, in the Nancy Andreasen study, when they first looked at people, there was some decrease in brain volumes, okay, before they went on drug, if I remember correctly. And I think there's some other studies that also say that's true. That literature is clouded because so often they say that if you look at the papers, these were drug-naive patients, but in fact they've been on drugs for about 3 months. And now we know that some of the loss happens quite rapidly. But I think actually if you look at the trauma literature, there's some sign of it across diagnoses and et cetera, some brain volume loss. So it could be a sign of stress on the brain, you know, environmental stress on the brain that does cause some sort of this harm to the brain. It makes perfect sense to me. Trauma, sexual trauma. You see a lot of sexual trauma in people so diagnosed. You know, that could do a lot to your mind.
You also see that when first-time schizophrenia patients are diagnosed with schizophrenia, they have a decrease in gray and white matter in the brain.
I think, for example, that's what Nancy Andreasen found. And then it kept going, and the question was, does the drug stop that, or does it add to it? And basically, she ended up with it adds to that brain volume loss.
Thank you.
Thank you so much. And thank you again, Bob.
You're welcome.